Hello, it's me, Dr. Shelley again. As promised, we are going to tap into a little endocrine. One of my favorite subjects. Cardio is actually my favorite of all time because I wanted to be a cardiac surgeon when I was a little girl, but endocrine is a close second because I want students to learn that it's really not that hard. Now, by now, you should know I already have a video out about Addison's and Cushing's, and this is going to be SIADH and DI. Now, the SIADH part is kind of like the focus, but you can't talk about SIADH without talking about DI. So for this video, you are going to need your endocrine packet. You know it looks like this. You probably know by now that we have a packet for every playlist, and if you ever needed a comprehensive NGN review course, self-study, we have that with every packet for every single system. So this is our endocrine packet. We're gonna start with something that doesn't say endocrine. It actually says renal compensation in shock. It talks about ADH. It talks about aldosterone. And of course, it talks about angiotensin. We're gonna start with that because it's easier to understand SIADH and DI if you know the basics, right? It's all about that pathophysiology, or as the NCLEX would call it, physiological adaptation. Yeah, $4 words. Also in this endocrine packet, you're gonna need to know another handout that we're gonna talk about is diabetes insipidus. And right after that is the couple of handouts that we use to focus on SIADH, which is another name for hyponatremia. Lots of other names we got to remember, okay? So let's get started. First of all, and I don't like the way this is going, so I'm going to move it a little bit. Hope that doesn't drive you too crazy, but you know, your girl's an amateur. I'm an amateur YouTuber, but I'm an expert NCLEXer, so stay with your girl, okay? Now, so let's go over here to this side of the board before we go skedaddling over to that side of the board. This side of the board talks about these hormones that your body produces as a way to compensate for fluid loss or fluid retention. Specifically, these hormones are produced especially in life and death matters called shock, okay? So that's why that handout said renal compensation in shock. Now, because we're not in shock when we go talking about SIADH, I want you to still understand what happens with shock because it affects so much of what you have to know for this NCLEX exam. And it will lead you into understanding a lot better some of these major hormones that take place in the human body when fluid imbalance is present. So here we go. There are 4. Did I tell you 4? Did you hear me say 4? Yeah, there's 4 triggers for any of these hormones. And again, don't forget the 4 hormones. The 4 hormones, because I know you forgot, the 4 hormones was ADH, antidiuretic hormone. The next one was Renin, and Renin has not a real role to play, minor role. The next one is angiotensin, and then the last one is aldosterone. So if you can rock and roll with your girl, you're gonna understand that there are 4 triggers to 4 hormones. The 4 triggers, number 1, is blood osmolarity. Now don't let that osmolarity word scare you. Osmolarity just means concentration, viscosity, thickness, right? So if I tell you your blood has a high osmolarity, then you should be thinking, ooh, my blood is really thick and probably needs some dilution with water. If I tell you that the urine in your body has a high osmolality, then you know that that means that the urine is concentrated. And you also know that if your urine is concentrated, then you probably have a what? High specific gravity. Okay, so I'm going to say that again. Y'all ready? High osmolarity of blood equals high concentration of blood. High osmolality of urine equals super concentrated urine. Okay, you got this. Now, for blood, we also want to remember high osmolarity, high concentration, thickness, viscosity, all those words. We have to remember those words, okay? Then we have to look at sodium. Sodium is another trigger for these hormones, and you can imagine why. Because the more sodium in your blood, the more concentrated the blood, right? I mean, it's kind of like common sense, right? So we want to be careful and think about how, if I have more sodium, sometimes that can increase concentrations, okay? So that's all I'm saying. If there's more sodium in the blood, then there's probably going to be more osmolarity of the blood. Blood pressure ain't no joke. It's another trigger for these hormones behind me. When you have a low blood pressure, you have low blood perfusing your organs, but especially your kidneys. So if you have low blood pressure, BP, you have low blood perfusing kidneys, then it's going to trigger a compensation response by making sure the body secretes hormones that will increase the blood pressure. Now, there's several different ways to increase blood pressure. You may have to increase blood volume because fluid controls blood pressure, or you may have to do something called vasoconstriction. And if you vasoconstrict all of your blood vessels, it's going to require that low blood pressure go a little bit higher because it takes higher pressures to push blood through vasoconstricted blood vessels. You see, it takes a higher blood pressure. So you vasoconstricted the blood vessels, now we need more blood pressure. Or you increase the blood volume and now the blood pressure is higher. Last trigger is blood volume. So if you have a low blood volume, maybe it's because you hemorrhaged. The body does not want you to go into hypovolemic shock, which is a result of hemorrhaging. And so it kicks in this compensation by having you do what? Trigger some of these hormones to cause you to retain fluid. Fluid volume helps, and stay alive. Hello. Now, that should have made sense, but let's look at my little board, okay? Here we go. Anti-diuretic hormone. And we all know what diuretics do. They make you pee. So if we're talking anti-diuretic, anti-pee-pee. So an anti-diuretic hormone is essentially an anti-pee-pee hormone. You got it? Now you got to remember, when's the last time we talked about pee-pee? We said that no BP equals decreased renal perfusion And no BP equals no PP, meaning if you can't perfuse your kidneys, you can't make urine. No BP, no PP. That's a lot. Now let's go back to our ADH. ADH, or antidiuretic hormone, is an anti-PP hormone. When you have too much of it, what are you doing? You're not peeing, you're holding on to fluid. When you don't have enough, you are peeing tremendously. All right. Now, what is it triggered by? Well, we talked a little bit about this, but there's specifics. It's triggered by, here we go again, high osmolarity, high sodium, low blood pressure, low blood volume. ADH, although it's produced by the hypothalamus, which will respond by triggering the thirst reflex, this hormone is actually secreted by the posterior pituitary. We call the posterior pituitary the PP part of the pituitary because it puts out ADH, or anti-PP hormone. Okay? Now, when it's secreted by the posterior pituitary, it is going to cause the human body to reabsorb or keep the water that it has, so we don't let any more out, right? Okay, so that pretty much means anti-diuretic, anti-PP, reabsorb water. Okay, now this ADH little system works directly with the RAAS system, the Renin, Angiotensin, Aldosterone system. So Renin is spelled this way. It looks suspiciously like renals or kidneys. Angiotensin comes after it. Aldosterone comes last, sort of, okay? So when we look at the RAAS system, make sure you take good notes, because again, in the endocrine, and also there's the same exact handout in your renal packet in case it sounds familiar, but what we're doing right now is we're taking notes on this page in your endocrine packet. So when we look at the RAAS system, we know that renin is secreted and the whole RAAS system is activated by a low blood pressure. So when the blood pressure is low and the renin system is activated, or the RAAS system is activated, renin is secreted, and it's a very mild, super mild vasoconstrictor. Doesn't do a whole lot for the blood pressure, but here's what it does. Renin, this mild vasoconstrictor produced by the kidneys, is going to trigger the liver to produce angiotensin. Angiotensin is two things. It's angiotensin 1 and it's angiotensin 2. This angiotensin 1 has to be converted to angiotensin 2 using an enzyme. Angiotensin converting enzyme, or ACE. Where have you heard that word before? ACE inhibitors. We'll talk. So angiotensin 1, which is converted in the lungs to angiotensin 2, then becomes a, number 1, potent vasoconstrictor. Shut those blood vessels down. Potent vasoconstrictor. That's 1. Number 2, it stimulates anti-diuretic hormone from the pituitary. Oh my God, that's a big deal because you already know what that does. And then number 3, are you listening? Number 3. What am I telling you? I'm telling you that angiotensin 2 has 3 actions. The third action is that Angiotensin 2 stimulates the adrenals to produce aldosterone, which is going to cause you to retain sodium and water, and sodium and water retention increase blood volume, and blood volume increases blood pressure, and the original trigger was low blood pressure in the first place, so now we brought our pressure up. So that's how we compensate in shock, right? Because everybody knows that all shock has a low blood pressure. Well, the body, because God made no mistakes, has its own mechanisms to save your little ass from dying from shock. And it's called the RAAS system, okay? So again, when blood pressure is low, renin is activated or secreted by the kidneys. It is a mild vasoconstrictor that triggers the liver to produce angiotensin 1. Angiotensin 1 is converted in the lungs into angiotensin 2, and angiotensin 2 has 3 major actions. Action number 1, it's a potent vasoconstrictor. You know that vasoconstriction raises blood pressure. Number 2 action, it stimulates the ADH or antidiuretic hormone production, I should say secretion, from the pituitary, the posterior pituitary, so you can retain what? Water. That increases blood volume. And then it stimulates the adrenals. Remember that? Adrenaline. Yeah. Angiotensin 2 stimulates the adrenals to produce aldosterone. And I want you to pay attention to this word, aldosterone. If you pay attention, there's something called sterone here. And this was called angiotensin here. I want you to think about that, because one of the things I try to help you understand is there's no way to pass NCLEX memorizing things. So you and I must get good at figuring things out through critically thinking. Now, my PhD is based on you being able to look at vocabulary and reading comprehension and pass tests. So one of the things I'm really good at is showing you the word itself to show you connections that you already know to help you pass NCLEX. Aldosterone looks like steroid, and we know that steroids increase your blood pressure and help you retain salt and water. And that's exactly what aldosterone does. It helps you retain sodium and water. When you look at the word angiotensin, if you work in a hospital, you may have even heard the word angiocath. Angiocath is a catheter or IV that goes in the angio or blood vessel. So angio means blood vessel. And in this case, angiotensin means putting tension on the blood vessel. So you're going to remember that angiotensin puts tension on the blood vessel, and that's called vasoconstriction. Vasoconstriction raises the blood pressure. Now, I said all that to say that you now understand the role that those hormones play, so that when we look at these two conditions, endocrine conditions, we can kind of have a really good heart-to-heart conversation, and I won't be blowing you away. Does that make sense? Now, I want to show you something, okay? Because I think the students learn better with stories. So here we go. What we have in my hands are 2 jars that are exactly alike. And yeah, they used to be candles. They were my limoncello candles, my favorite kind of candle. And so we have these 2 jars that are exactly alike. And this video is about SIADH. So what I want to tell you is that if I put a teaspoon of salt in this jar and a teaspoon of salt in this jar, I have the exact same amount of salt or sodium in each container. However, if I fill this container with half water, but then I fill this container all the way up to the top until it ran over with water, even though I have the exact same amount of sodium in each of these jars, which one is dilute and probably even hyponatremic? In other words, same amount of salt in each jar. Half a jar of water. I put water in here, but I only filled it halfway. I put water in here and I filled it all the way till it almost ran over. This jar or this jar, which one has more water? This one. Which one has less sodium? This one, because the effects of sodium I diluted with more water. So you have something called, watch this, water intoxication and hyponatremia, which is SIADH. Woo, that's important, honey, because I started off with the same exact amount of sodium, 1 teaspoon, 1 teaspoon. Filled this cup up halfway with water, overflowed this one. This one is hyponatremic, even though they started out with the same amount of salt. Now let's talk shop, because I need you to know, how would this play out in real people? Well, first of all, we have in Cleveland, Ohio, we had a story during the recession of 2007 and 2008. We have a horribly tragic story of a young lady who had just had her baby, brand new baby, right? And you know something about babies. They're 80% water. Her brand new baby was brought home from the hospital, but her husband had lost his job. Therefore, trying to buy formula for this precious brand new baby became almost prohibitive, like really hard to do. And formula's like $40, $50 a can, okay? So let's call it what it is. And that damn can may or may not last a whole week, okay? So this is very expensive. So what she thought she would do is she would make her son these bottles of milk formula for him to eat, but she would water it down a bit because she didn't have enough to stretch for the time frame because her husband lost his job. Now, a nurse would have been able to help her with the recommendation and the referral for WIC, right? Women's, infants, children. But that didn't happen, and we don't know why, but we know that she watered down this powdered formula for a baby who's already 80% water. We also know that nurses always teach new moms, and sometimes they even have to teach grandmas, you cannot give a new baby water, straight water. No, they don't need any water for at least 6 months. They need food. So now we've taken the food and we've watered it down. This precious baby was fed this watered down formula and began to have seizures. That makes sense to me, because look, that baby with all that water, who's already 80% water, this fluid volume overload or fluid retention caused this precious child to have high blood pressure, low sodium, seizures. This child was vomiting, and this precious child was admitted to Metro Health Medical Center, which is our county hospital for really, 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 really sick babies. So, you know, this is horrible, okay? Let's do another one because stories really matter. There was also a water drinking contest on the radio station here in Cleveland, Ohio. Let's just say this. The winner of the water drinking contest Yeah, he's dead. Because even adults can become water intoxicated. And this winner of this water drinking contest died because when you drink that much water, you dilute the effects of your sodium, and then that's deadly. Yeah, I know, it's crazy. So I want you to think of the fact that anytime the human body is full of so much water that the sodium in the human body is dilute and the effects of sodium are dilute, so that when the blood is drawn, it looks low. It's, normal sodium is 135 to 145. This is like way less than that, even down to the 110s, 115s. This is very, very low sodium levels because of the dilution of the water. Those patients are really at risk for dying. And some of those fluid volume overload conditions include CHF or cirrhosis and those sorts of things. So you kind of got to know your stuff, okay? Now, so let's go over to the board and see what we got when we get a low sodium, okay? So we have syndrome of inappropriate anti-diuretic hormone. That's way too much shit to say. This is how I want you to say it. SI means high ADH. SI means high ADH. SI means high ADH. SI means high ADH. I don't know what that was, but something fell. Everything is, crazy in Shelley's Nursing Review. But you think I was jumping too much? Maybe I was getting down real hard and maybe something failed, but whatever. SI means high ADH. Now, there is an I right here, right next to ADH. Let that I be a guide to say increased anti-diuretic hormone. That should help you. And SI means high ADH really means that SI is high in everything else. So let's find out what SI is high in. All things high. SI is high in the pulse, the blood pressure, the ADH, the potassium, the specific gravity, the fluid, and that's crazy. Okay, so we turned an endocrine disorder into like a little bit of neuro right then. I don't know if you caught it, but blood pressure and headache always go together, right? Now, so here's our deal. We have fluid overload on the body. You know that no matter what, if you have too much fluid on the body, the heart's going to beat faster trying to clear this fluid, and it's going to beat faster trying to move all this fluid around the body. The quality of the pulse then on any test would be rapid bounding pulse. Think of it this way. If I am in a swimming pool full of water and I try to run, it's going to be a real bounding type of run because I need so much strength and so much power behind every beat and every step that it's bounding, leaps and bounds through that swimming pool. Too much water, bounding pulse. The blood pressure, we talked about it, that blood volume increases your blood pressure. So of course, fluid retention is going to lead to an increased blood pressure. What was the cause? Too much anti-diuretic hormone, which means you have too much fluid on board, because too much anti-diuretic hormone means too much anti-PP, and you're never peeing it out. So it's still on the human body. High potassium. That makes sense because the other name for SIADH is hyponatremia, right? That's the other name for it. So if the other name is hyponatremia, and we know that sodium and potassium are direct opposites, Well, then if sodium is low, potassium is high. There is a high specific gravity. Earlier we talked about osmolarity, osmolality. We said that osmolarity and osmolality are concentrations. We know that this patient has all the fluid in the body, none in the urine. So this patient's specific gravity of their urine is high. Their urine has hardly no water in it. And if the specific gravity of the urine is high, then that urine is dark, concentrated urine. That makes sense. However, this is a little weird because instead of extreme edema, no, it's mild edema because it has to do with ADH and not other issues. Unless there's some heart failure or something else going on where the edema might be significant. Because the sodium is so low and dilute, this patient starts vomiting, like they're throwing up, nausea and vomiting. They definitely have a headache because blood pressure and headache go together. High blood pressure and headache go together. And when they're together like they are in this patient, the logical conclusion is that the patient is at risk for seizures and even high ICP, which means if they're at risk for high ICP, well, guess what? You can expect maybe some confusion or altered mental status. They're confused a lot of times. This is not that uncommon, okay? I already said ADH is high, so it's not letting any water out of the body. It's an anti-diuretic. It's an anti-PP. No fluid is leaving the body. So that means we have oliguria. Our blood in our body has so much water diluting it that the osmolarity is low, lower than 300. Write that down. Yeah, I said it. Lower than 300. I hope you got it. Low blood osmolarity, lower, much lower than 300. The DTRs, or deep tendon reflexes, may be brisk because we are pre-seizure. The sodium is, as the word states, hyponatremic. The urine is dark, as we said. Now, what's the cure? What do we do to treat the patient? Well, we have a couple things to keep in mind. First of all, this patient needs a serious fluid restriction. There was a Grey's Anatomy that does this kind of episode with a patient in there having SIADH, and they were put on a fluid restriction. And they were found drinking out the toilet because they were so desperate to drink. We use hypertonic IV solutions for this patient, like 3% sodium chloride. Yes, you have to know that. And then we are very strict about monitoring daily weights and I's and O's. Now, let's talk about the daily weights, because I don't know if you know, but anybody on diuretics, anybody on more than one hypertension medication, anybody with heart failure, anybody with liver failure, anybody with renal failure should be doing daily weights. But let's find out why. We know that 2.2 pounds is the same as 1 kilogram. We also know that 1 kilogram is the same as 1 liter of fluid. So you know how in the hospital you saw these big IV bags, right? Lactated ringers, normal saline, IV bags. That whole bag is a liter. Some of you don't know too much about that, so let me break it on down to you, honey. You know the 2-liter bottles of pop? I thought you would. Those 2-liter bottles of pop or soda, if you're not from Cleveland, those 2-liter bottles, huge bottles, that's half, or I should say that's twice as much fluid being retained in the body. So if you poured out half of that 2-liter bottle of pop or soda out, you were left with 1 liter. That's how much extra is on the human body when you gain 2.2 pounds. So that's why we tell patients, please call us if you gain more than 3 pounds in a day or 5 pounds in a week, because we know we're talking about your body is retaining liters of fluid, which is going to cause your heart to work very hard. It's going to cause your blood pressure to go up, and that's why we do our daily weights. Now, this video was very focused on SIADH and ADH. However, I would not be who I am if I didn't show you how easy it is to get DI and understand it based on your understanding of SIADH. So let's do a quickie on DI. First of all, I have a couple of tricks up my sleeve for DI, and that's because DI is rare. It is, it's rare. SIADH is not so rare. So when it comes to SIADH, any organ failure, the heart failure, the kidney failure, the liver failure patient could slide right into SIADH. It could be an issue of water intoxication where we're watering down formula for a baby, or we are drinking way too much water for our body, water drinking contest. There's a lot of different reasons why a patient could slide into some scary SIADH. But the DI, which is the exact opposite, is very much rare. Now with DI, and you do have that handout in your endocrine packet, with DI, I use tricks because it is rare and it's hard to understand. So here's some tricks. There are basically 10 Ds with DI, 3 Ps, and then we have only 3 highs of DI. So when we say the 3 highs of DI, that means that everything else is low. Yeah, you got it. 3 highs of DI and everything else is low. So that's why the D, because you know she loves the D. That's why the Ds are important, and we'll go over them now. So let's do it. D for diabetes insipidus is 1. Let's label it, shall we? D is 1, DI. Now, most of your tests will still say DI, diabetes insipidus. Has nothing to do with sugar, has nothing to do with diabetes mellitus. It's DI, nothing to do with anything with sugar. So don't ever include sugar in this, okay? So that was 1. That was one of your Ds, and I said she loves the D. All right. Now, the next D is that everything is decreased. But before we do that, we do have to talk about the pulse. Because watch this. The only thing that DI shares with SIADH is tachycardia. But the quality of the pulse is very weak and thready, not bounding. Weak and thready is the opposite of bounding. Now that you got that out the way, we're going to go into our Ds because, again, she loves the D. Here we go. Decreased blood pressure. You know that because this patient is the exact opposite of SIADH, and instead of fluid retention, they're dehydrated or fluid volume deficit. And you know that fluid volume controls blood pressure, so it just makes sense. Decreased ADH for whatever reason. So ADH was the anti-diuretic hormone or anti-PP hormone, and you don't have any. So what are you doing if you don't have any anti-PP hormone? You're peeing, right? And you can't stop. Like, you can't stop. Number 4 is a decreased potassium. Now, you know why. Sodium was low in SIADH. Well, it's high in DI. Now that's one of our 3 highs of DI, but if sodium is high, then potassium is, you guessed it, low. I hope this helps. So far we have 4 Ds. D for DI, D for decreased blood pressure, D for decreased antidiuretic hormone, D for decreased potassium. Number 5 is decreased specific gravity. Remember how everything in the urine was concentrated here? Well, this is a decreased specific gravity. So it's not concentrated, it's dilute. And so what color is this urine? It's pale. Decreased skin turgor. It's poor, right? It's horrible. You have none. And so we use the forehead or the sternum for the elderly, the skin on the arm for regular folk, and it's poor skin turgor. Number 7 is D for dehydration. You knew that. These are exact opposites. This was fluid retention. This is dehydration. Number 8 is the word dizzy. So D for dizzy. Why? Well, you know that this word dizzy goes with this blood pressure, decreased. Dizzy and syncope always go with a low blood pressure. Then you have the decreased weight, meaning this patient has lost weight. They're down on their weight, decreased weight. And that's number 9. Number 10 is the almighty treatment. Are you ready? Number 10 is DDAVP. DDAVP, which is synthetic ADH. And that's important. DDAVP is synthetic ADH, arginine vasopressin. Now, what that means is that the V and the P, and even this A, this V and this P means vasopressin. Now, I taught you back here that you've got to look at words and really figure them out. And somehow that's how you get the NCLEX questions correct. Because if you think vasopressin, pressing the blood vessel, what did you do? You vasoconstricted. You got it. If I cannot stop peeing, then I need somebody to shut it down, to vasoconstrict and shut it down. And that's what vasopressin does. Now, of course, same shit, different day. Strict I's and O's. But in this guy's case, no fluid restriction. No. Push fluids, right? Now, I said 10 D's of DI, 3 P's, and 3 highs. Here's your P for polyuria, polydipsia, pale urine. 1, 2, 3. 3 P's and 3 highs of DI. Now, what's the 3 highs? The 3 highs of DI is sodium, osmolarity, and where is the third one? Increased urine, polyuria. So you have 3 highs of DI. 1, 2, 3. High urine output, high osmolarity, high sodium. Now, as we close on this SIADH video, I'm just going to go back and forth to show you literally how if you know one of these, you know them both. All right, so diabetes insipidus is the opposite of SIADH, which is hyponatremia or water intoxication. Tachycardia is the only thing they share. Diabetes insipidus has a weak, thready pulse. SIADH has a bounding pulse. Decreased BP, high BP. Decreased ADH, high ADH. Decreased potassium, high potassium. Decreased specific gravity, high specific gravity. Poor skin turgor, skin edema. Dehydration, fluid retention. Dizzy, headache. Weight loss, where is it? It should be on here. Oh, I don't see it. Let's add it, you guys. I don't see it. It should be on here. We can put weight gain or increased weight. Shame, 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 huh? There you go. All right. So decrease weight, increase weight. Polyuria, oliguria. Increased osmolarity, decreased osmolarity. Polydipsia just means increased thirst. High sodium, low sodium. Pale urine, dark urine. Fluid restriction, push fluids. I think that should help you. I do. Now, I gotta go because I'm tired and I want to get out of here. But I really hope that this helps. Remember, the answers to the quiz, if you didn't get them already, will be posted tomorrow. Deuces.